Medicine, to the organizers, to the Kellogg Foundation for including me as part of this panel. Just as a disclosure, I am the CEO and founder of an electronic health record and HIT platform for maternity care. So starting from the perspective of home birth, I don't think that we can really talk, I'm at an advantage because I'm going last, and almost everything in my presentation has already been said in some way or some form. So I'm going to try to move really quickly through some slides. But I think as we sort of sit and what's already become obvious and has been handled very well and respectfully in this setting is that the environment of home birth in the United States can't really be understated in its relationship to context around the research and how we look at things. So from the viewpoint of our polarized perspectives, that we as home birth providers are marginalized and not integrated into the system, disruptive both in however you respond to that word, disruptive maybe in a good way from an innovative perspective, from sitting outside, looking in and not being part of the system, we have an opportunity to provide insight, and at the same time considering how to integrate us into the system will disrupt the system a bit in a way, and depending on your perspective and the polarization, that's a good or a bad thing. And race is such an issue that we can't understate enough of how this disparity around access to choice of where to birth is really an issue of race. And of course, politics. I don't need to go into the wax deconstruction. I think I really want to talk about it from the perspective of the burden it is as a provider for both me and the women that I'm providing informed consent when there is disagreement among the experts and the researchers around the outcomes of the research that's published. So I just really wanted to bring that perspective forward, that it really impacts the trust in being able to look at things that are printed in journals when we don't have agreement around the information. And another thing that really hasn't been addressed is the impact on the media of these kinds of journals. And so when the professional association takes a position based on a controversial study, and then the New York Times picks it up as a headline and draws conclusions based on causal relationships that are extrapolated by the authors that weren't in the systematic review. In particular, I'm talking about the association of low intervention to higher neonatal death that I think was really, really unfortunate that was reported in the New York Times. And then, of course, adding to the politics, I just wanted to put another random map up for us all to review. This one is a loose interpretation of where things are happening legislatively for CPMs. With the blue states, not with any political alignment towards a blue sense, is where CPMs legally practice. But in almost all the states, there's some amount of organization and interest in getting licensure. And the impact of these position statements aren't just about advising women on what kind of choice they want to make. It's about getting access to licensure and the impact that it had just 2 days ago in Maryland, and today in North Carolina, and last week in Indiana, has to do with what we're talking about here, and I wanted to kind of draw the connection to the implication of that research. We've already talked about why women choose home birth, so I'm going to, at the same time that I'd like to spend more time here in talking about women's perspectives and why they make these choices, I think the overriding theme, and these are quotes from my practice, where we ask every woman as part of intake, why are you making the choice to have home birth? It's consistent with the research that the overriding issue is safety, control, and comfort. We haven't talked about the Cochrane Collaborative and the review on home birth. I wanted to bring it up mostly from the perspective of the conclusions and issues of autonomy. And we talked about absolute risk versus relative risk. And the question that I think needs to get asked is, how low does the absolute risk need to be, or how high does the absolute risk need to be to actually limit women's choices for this birth setting? Because currently that's what we have, is a limitation of choice based on an assumption around relative risk, rather than an assumption of a low absolute risk shouldn't impede the ability to make this decision. I'm going to jump over this because this has already been talked about, but we haven't really talked about some of the big, great studies that influence me as a provider when I'm thinking about getting informed consent. And I really want to get into it. Once we establish that home birth from an absolute risk perspective is safe, how can we make it safer? And so these are some of the things that we can research and look at around safety and home birth. Obviously, access to qualified care providers with appropriate equipment is a huge issue. Appropriate risk assessment, communication, and collaboration cannot be understated as being instrumental. But the integrated transfer of data, these things have already been said, quality improvement measures, access to licensure, and reimbursement. And I think what I want to say, just to add to the ongoing conversation about risk assessment, is really more about the value judgment of safety. Because we talk about risk as though assuming we can get to zero on risk on birth. And I think that if we can really come from the viewpoint of is it safe, as opposed to how risky is it, goes back to this idea of autonomy and the ability to make that choice. And that really from that perspective of what is your level of acceptable risk is your definition of safety, and that's where the disagreement is. And that's where the provider perspective versus the patient perspective really comes in as well. And one other really important relationship to the risk assessment conversation that hasn't come up is that when we assume that we will limit access to certain locations because of risk, we have to consider what the other locations are offering. And this is a photo in which a hospital has banned VBAC, and women are literally standing outside picketing about wanting access to VBAC in the hospital. And I would love, as a home birth provider, to not have those women coming to me to ask me for that option because they have nowhere else to go. I think it's an important thing to think about it. So the concept of mutual respect is again sort of reiterated here. I want to say I practice in Charlottesville, Virginia, in a highly positive, I would say great example. It's not a collaborative relationship that we have with the University of Virginia. What we have is an accepted understanding that women are going to choose this. And we have physicians who greet women in the setting with a transport, with an understanding that they are now going to be the experts advising them on their care. And they say, usually almost to a person, I know this wasn't your plan, this isn't where you wanted to be, but now I'm going to be caring for you. And they acknowledge me as the midwife. Whatever they think about home birth, they know that I have a very specific expertise, which is that I know this woman, and they don't. And if they can engage me in the process, it improves the communication, it improves the engagement, and usually have a higher satisfaction in the lower cesarean section rate. Although the cesarean section rate is sort of irrelevant at that point. It's the quality of care and the empowerment in the sense of, am I still being heard and am I not being shamed for a choice that I made, which is obviously a huge fear. Talked a lot about interpartum transport. I think I will give my bias and just say that we would be derelict to not consider efficiencies of interpartum transport from the data collection perspective, from the HIT view, and the opportunities that we have to integrate data interoperability from home birth and birth center providers to hospitals to be able to get the right data in a timely manner. I don't even know where to begin on this slide, and I think from the viewpoint, I thought about it a lot. I think we need an entire conference about shared decision-making in maternity care. There is so much complexity to the ethics here, and I think they've come up today in a lot of the comments. But in light of the Affordable Care Act, bringing in views around preference-sensitive care and what it means to have values and preferences incorporated in decision-making and its application to maternity care cannot be understated as a critical point for patient safety in maternity care moving forward. And I think we could all get together on this. All providers deal with these same issues, and I think we can really move forward potentially with this kind of discussion. Race disparity, I think it has to be addressed. We talked about it today with a sort of head-scratching, gee, what do we do? One thing that was just published was the doula study that looked about doulas reducing cesarean section rates in Medicaid patients. So the idea of community-based health workers, not just midwives, but all kinds of community-based health workers in maternity care who could be added to the equation in the discussion. Relocation and rural care, I think thinking about that, the aspect of distance to birth and what we might be thinking about in terms of making birth for rural women safer. And then I want to sort of end and sort of talk about this concept of home birth like. And I want to tell you as a home birth provider what I would need to see, or what I would suggest would have to be some of the driving factors to have home birth like. First of all, that it's woman-centered, family-friendly, engaging whoever the woman identifies as her family, and recognizing that home-like, from a Western view, doesn't necessarily always feel like home. So we can't just put gingham curtains on the wall and think that most people are going to feel like that feels like home to them. So it's a relative term that is hard to replicate when you're talking about the diversity that we have. We also have to engage the entire course of pregnancy in the concepts around where the birth is happening. So recognizing that pregnancy and birth are unified, and that they have to include social and emotional, physical, cultural, and spiritual accommodation in order to be home-like, in order to give that view. And most importantly is that home birth currently is a resolute environment for undisturbed physiologic birth. It is where it's happening in the United States, and it's a place we should look to better understand what physiologic birth looks like. All kinds of factors that can disturb physiologic birth that can be a part of that. need to be addressed in terms of actually being able to improve hospital situations, to look more like home. And we need to recognize that there's more science and more study that could be done around the epigenetics of the impact on these disruptions to the birth process. That it isn't just about where do you feel comfortable, where do you want to have your birth, how satisfied you want to be, but what is the impact on the mother-baby dyad with all of these interventions, and how can we bring that? I commend the idea of bringing that to the hospital, and I would love to be a part of helping make that happen. And I'll close with this photo. It looks like I might have a little bit of time to talk about it. This is one of my clients, and I put this slide in because I felt like it was this whole experience of this birth was very important to me and very emblematic of what home birth looks like. And I ended up having an exchange with the Institute of Medicine staff around whether it was appropriate, given that we're on the web and that people might see this photo. My own experience with the exchange that we had and my encouragement in letting them have it be in here for you to see is that there's a clinical significance to what parts of this photo are there. And I had myself really thought about my own bias as a home birth provider about what it would mean to have a woman unencumbered at a birth in a hospital. Because in my experience, whether someone has clothes on or has a hospital gown on or what is there and what's there, this is normative to me. And some of the things that I want to just unpack for you are the evidence of delayed cord clamping, the fact that she's upright, the fact that there is no provider in the photo messing with her. She's holding her own baby, who is quite pink, and I will admit I probably gave an APGAR of 10. And in the experience of what happened for her, she is about 100 pounds pre-pregnant, and that baby is over 4,000 grams. It's not just an over 4,000 gram baby delivered over an intact perineum in 30 minutes of pushing. It's more than that. It's the evidence of physiologic birth, because her last 30 minutes of second stage were spent in the position that she found herself most comfortable, unencumbered, on her knees, bent over the mattress, making sounds, moving her body. And as she pushed this baby out in about 3 good pushes, her entire sacrum hinged about 3 centimeters in order to accommodate this big guy. And she spontaneously reached down and picked him up and brought him to her chest. And all I could do is step back and witness that, because there really wasn't anything for me to do. And those are the best births, right? You know, that's sort of what we want. I feel like in all of that entirety, this is not what hospital providers see when they think about home birth. And I felt like it was really important for us all to witness it and be able to have this conversation about what's possible and include that in our dialogue moving forward. So thank you for my time, and I thank you again to the Institute of Medicine for letting me include it.